Thanks, John. And Isabel Redmond, Leader of Opposition, to Mitch Williams, our local member and Deputy Leader of Opposition, to Mayor Diana Penniman, Chairman James DeBarrow, but most importantly to all of you here tonight from the various communities around the Tatiara and up to Tintinara. And it is absolutely outstanding to see you here tonight. Most of you are probably sick of hearing my voice over the last few days, but it has been important to raise the profile of this critical issue. The hospital has many services and our doctors are the most important critical pillars of our communities. Everyone understands that, but unfortunately from time to time that message gets lost in Adelaide. It's my job tonight to try and give you an understanding of how our hospital works and how it's funded. Peter's given you a good history of the hospital, and what that has resulted in is that we have, and there's some terms tonight that I'm trying to explain. When I use the word acute bed, that just means normal hospital bed. That's the bed you go into when you go to hospital. The other section of our hospital in the aged care wing are aged care beds. That's pretty straightforward. So when you hear acute, just read normal hospital bed. So Keith is currently licensed for 14 acute beds. On average, we have a bit over 5 patients a night in there, and a bit over 1 of those on average is a public patient, as opposed to the other 4 being private patients. And in other words, those people, like most of you here, have taken out private health insurance, and your health funds are paying that cost as opposed to the Keith Hospital or the state government. For the last 7 or 8 years now, we've also had our aged care wing, which was generously 2/3 funded by the federal government and 1/3 funded by the hospital and the local community, and primarily through a separate rate that went on to West Ward rate notices. So the state government had no input into that. Aged care is a federal government responsibility, and so we have 18 licensed beds there. And so long as we keep them full, which is normally not a problem, that section of our business is part of what makes us potentially viable. We also have our accident and emergency services. Everyone's aware of what they do. We're on the busy Dukes Highway and all those implications Peter's talked about, and James have both been ambulance officers, and many others of you here do SES or ambulance or are members of the CFS. The hospital also runs the general practice in the main street, and as most of you are probably aware, in a month's time that will be relocating up to the hill wing of the hospital, which has been redeveloped to be a new medical centre, and once again funding from the federal government for that refurbishment of approximately 2/3 of the cost, and the other 1/3 once again being paid for by all of us here tonight with our donations, and once again a separate rate on our rate notices. So the federal government in recent times has continually recognised the regional significance and strategic significance of Keith in providing comprehensive health services. I'm also here to talk about how we make it all work. So we have an aged care wing with 18 beds, the normal hospital section, which we call acute, with 14 beds, accident emergency, outpatient services, and in future we will have the medical centre with the GPs operating there, visiting specialists, allied health, the dentist, and potentially other services as well. And this will once again give us some increased business efficiencies, which we're constantly having to undertake to remain in business. What I wanted to go and talk about now is where our money comes from. And Sarah Martin, who is chairs our finance committee, seeing as I can't be in 2 places at once, Sarah will highlight for you, and she should possibly do it from the other side, so I don't know what she's pointing to, where we get our money. We have 3 main funding sources before we go into the detail over there. We receive monies from the federal government based on activity in the aged care beds. We receive a grant from the state government for one hospital bed, or acute care bed as we call them. Helps to pay for some of our accident and emergency services, pays for 2 nursing home type beds, and helps to pay for some of our ambulance transfer costs, which we wear internally when patients are transferred from Keith to hospitals, principally off to Adelaide. Now, I think the first chart we have over there is from 2005, and this gives us an insight into our funding dilemma. About 3 years before that chart there, the section where it says CHSA, Country Health South Australia funding, that represented 3 years before that chart about 35%, and that chart there, it's already dropped down to, let me get it right, 31%. As a consequence of that, that trend that had already dropped from 35 to 31, 3 years ago, Bill Hender and myself, in the company of our local member Mitch Williams, went to see Minister Hill because we could see then that that trend was unsustainable, that eventually that was going to lead, due to that portion of our funding decreasing, that was going to eventually create trouble for us. So back then you had that 31% from Country Health SA, 39% from our aged care beds, which is purely activity based in relation to those 18 federally funded aged care beds, and then 22% from our private hospital beds from private health funds. And then there's another small section there of 8%. By the time we move along to 2010, you can see that trend has kept going. The Country Health SA percentage has dropped to 26% from 31. The aged care proportion has gone up slightly to 42, representing that the payment received for those beds is been keeping up with inflation, and we've kept the facility relatively full. And the private component has gone up slightly from 22% to 25%. When we fast forward to 2011, and this represents the position at July 1 next year, with the state government's recent announcement, so that in 2010, that 26% in dollar terms was $663,000 out of a total expenditure of approximately 2.6 million. And the proposition for next year is that be reduced to $300,000, a reduction of $370,000. And you can see the effect that has. That 26% has gone down to 11%. And remembering that in 2005 it was 31, and 3 years before that it was 35. The other estate, much the same. Aged care, much the same at 38, and the private has gone up slightly more again to 26. But given that our budget was already a small deficit budget, to blow that out by $370,000 in addition in one hit, that's the end. Boards are bound by the protocols of insolvency laws, and we have to abide by those regulations. So our challenge, given how important providing all those services to our community in the future, in reality, what we currently provide, where we use the same staff for the aged care residents, for the people in the normal hospital beds, and who are available for accident and emergencies, and to provide outpatient services as well, we use all those same staff to cover all those different tasks. As soon as you take, especially at night times and weekends when we're able to run at the minimum staffing level, if you take one of those enterprises away, it makes no difference to your costs. All that happens is your income goes down. So I guess the best analogy is like the classic mixed farm. If one of your enterprises falls over, the whole business falls over. And that's what we're talking about here. there is very little to be gained in terms of costs by reducing those services, that our income is considerably diminished.